A very good afternoon and a warm welcome to all the respected doctors who have joined us this afternoon for yet another session in the series of NEFFRON, which is an expert curated lecture series for physicians who deal with kidney disorders in their day to day practice. To share a brief concept of this particular session, today's session will be focusing on diabetic nephropathy. And today we are very fortunate to have with us the clinical expert for the today session, Dr. Neha Jain Agarwal. Dr. Neha Jain Agarwal is an MBBS and MD internal medicine, KGMU University, DNB Nephrology from PSRI. She's a director and consultant nephrologist at RC Multi Speciality Hospital and Trauma Center, Bijnor. She has expertise in renal transplantation, dialysis, and critical care nephrology. She is a published researcher with multiple peer reviewed publications in nephrology and internal medicine, and she is also an active member of ISOT and ISL. So, with this, I would like to hand over the session to Dr. Neha Jain Agarwal, who will be guiding the audience today on a very important topic that is an approach to diabetic nephropathy. Thank you, ma'am.
Thank you, Ms. Anjali, for a kind introduction. And I thank the team Saffron for organizing such events. And I welcome all the doctors who are here to listen to this talk. And thank you so much for joining here. Kindly allow me to share my screen.
Yes, ma'am, done.
Okay. All right, just wait a minute. I'll just do it. So, okay. We are here to discuss today a very common topic which we deal every day, and it's a very important disease that we discuss. So this is diabetic kidney disease, and we know it for decades together now. For more than 50, 60 years we had been dealing with it, and yet we have not found the correct treatment protocol guidelines to manage it properly. We still see so many patients ending up in ESRD, needing dialysis or transplants. We are working hard, we are doing every possible thing to save our patient, but we're still not at the right path. So we'll discuss how to retard these complications, progression, and what is coming as newer guidelines. So to discuss brief about the prevalence and the incidence. So we all know that type 2 diabetes is the leading risk factor for the CKD progression as well as cardiovascular disease. So it hits where it hits hard. So it is leading to ESRD. In terms of CKD burden, we can see that every 1/3 of the patient, like every 1 in 3 patients are landing in landing in CKD. So we can measure that by the incidence or prevalence of albuminuria. Around 37% of the patients, they are developing albuminuria. This microalbuminuria leading to microalbuminuria, and later it is leading to CKD and sometimes ESRD. And we have like 10 times higher risk of kidney failure in diabetic population compared to non-diabetic patients. Similarly, if we see the cardiovascular disease burden, we see that diabetic patients are at 2 to 3 times higher risk of developing CVD, and they are higher risk of hospitalization and reduced survival in our patient. So this disease is very serious in terms of life expectancy as well. It shortens the lifespan very seriously. We see here, if the man or woman, they have only early CKD, no diabetes, and by early CKD means like the GFR is around 60, 70, or maybe 90, and proteinuria is usually microalbuminuria, that is less than 300 milligram per gram of creatinine. And with this performa, we see that around 5 to 7 years of life are lost in these patients by having only early CKD. If you have diabetes but no CKD, then also the 10 to 12 years of life is shortened by having prevalence of diabetes. And if you have both together, the early CKD and diabetes, then it seriously decreases your lifespan by 14 to 16 years in men and women. And this is the gravity and seriousness of disease, which we do not actually retard properly. So we'll discuss how we can pick the disease. The major concern about the CKD progression and maintenance and retardation, we see there are few factors so that we can diagnose the CKD, DKD properly. In diabetes patient, if you have incidence of CKD, then we consider it DKD only, diabetic kidney disease, unless proved otherwise. So there are few factors. If they are there, then we should investigate them in other terms. Otherwise, it is considered diabetic kidney disease only. So as we all know that if the patient has diabetes, the microvascular complication like diabetic retinopathy, diabetic nephropathy, and peripheral neuropathy, these together, these appear together in such patients. So if you do not have diabetic retinopathy and you have some proteinuria or decline in GFR, then we should consider some other diagnosis rather than DKD. The DKD is a slowly progressive disease, so it decreases the GFR slowly over the years. So if you sometimes find a rapidly declining GFR or very high creatinine, which was the normal 2-3 months back, then it is usually some other disease, not likely to be DKD, but like other complications, maybe pyelonephritis, maybe some other thing. If you have rapidly increasing proteinuria, diabetes takes very long time to develop proteinuria, and for maybe 5 to 10 years. Then from micro to macro proteinuria, it takes another 5 to 10 years. So it is a very slowly progressive disease. So if you find someone with having very severely rising proteinuria in a very small period of time, maybe 2-3 months, then it might be some other disease. It should be investigated and maybe biopsied as well. If you have patient with refractory hypertension, then sometimes it could be renal artery stenosis or some other disease, or secondary secondary parameters should be considered in such patients. If you have presence of active urinary sediments like RBC or RBC cast or fragmented RBCs or some other things, then like maybe broadcast sometimes, then it also indicates some other disease other than DKD. Some glomerulonephritis may be there in such patients. If you have signs and symptoms of other systemic illness, like you have malar rash or polyarthralgia, then you might think of lupus or some other disease. So these things also should be kept in mind. If you have reduction in GFR within 2-3 months after initiation of ACE inhibitor or ARB, because ACE inhibitors dilates the afferent arterioles, so they decrease the glomerular hypertension. So there is some decline in GFR. Usually, this is less than like 10 to 20% only, or maybe 12%. But if it is persistent and this normal decline in GFR, it improves with time. Over the months, it improves itself while favoring the kidney outcomes on the long term. But if it is 30% and it is progressive and not reversible, then you should think of some other diagnosis, maybe renal artery stenosis or something else. So these patients should be thoroughly investigated or not should be considered the DKD presentersly. Okay. So how do we assess? Whenever we think of kidney disease, DKD, or maybe any kidney disease, we think of like the creatinine. In the general public perception is that there is a kidney disease, there might be a rise in creatinine, but it is not true. In fact, in the guidelines, we can see here the guideline do not mention creatinine in the diagnosis of CKD. Okay, so creatinine is only one part of it. We can follow a patient properly with the help of creatinine, but it's not the diagnostic criteria of diagnosing DKD. In fact, creatinine is there in the diagnosis of AKI staging and everything, but it's not there in the CKD. So, okay, then what is there for diagnosis and prognosis? It is the albuminuria and the GFR. They are the two most important parameters which we often neglect or forget. These are the important parameters that we should look for. About the GFR, we think creatinine is the supermost thing. Actually, creatinine and GFR are interdependent. Once the creatinine rises, there is decline in GFR. And it doesn't need any other instrument or any other testing to be done separately. With the creatinine itself, it can be derived. So ask your lab persons whoever are doing the creatinine testing that they should mention GFR along with the creatinine. Then only we can actually do the correct diagnosis and treatment staging. In fact, if they are not doing, you can calculate it by the GFR formula, which is there like 140 minus age into weight divided by 72 and creatinine. This is the formula. With this formula, we can calculate eGFR ourselves. So, okay, so this is one important thing that we need to think. And the other important thing is albuminuria. What is the perception overall in rural area that they think that if there is 1 plus protein, it is not a big deal. It's like, okay, you can just forget it. That is the perception with when the patient come to us, ma'am, just there is mild proteinuria and creatinine is 1.2, it is not a big deal. It is actually a big deal. This is the time when we can intervene and we can save those 16 years or maybe longer years which are there with the patient, and they can be shortened because of some ignorance. Okay, so the assessment here, the definition of CKD is it is defined as the abnormalities in kidney structure or function which is present for more than 3 months, which has implication for health. And for diagnosis, we need to demonstrate the albuminuria, which should be more than 30 milligram per gram of creatinine, and GFR should be less than 60 well per minute per 1.73 meters square. So these are very simple tests and they are available everywhere. It's not or they are not very costly also. So they must be done in all the diabetic patients. In patients who have been diagnosed with type 2 diabetes, they should be diagnosed at when they are diagnosed with diabetes, and then yearly after. And in patients with the T1DM, we should do it after 5 years of diagnosis. Okay, so we will discuss here. This is what a very important slide. We'll discuss the risk of progression of kidney disease in terms of albuminuria and GFR. We divide this chart into the three parts. A1 is the less than 30 milligram ACR. This is the safer zone. A2 with 30 to 300 milligram of proteinuria, albuminuria, and A3 is more than 300. GFR is divided into 5 categories: more than 90, 60 to 90. Then we have 30 to 60, G3 stage. G4 is 50 to 30. And then G5 is less than 15. Less than 15, we can consider it ESRD. And at this stage, we consider renal replacement therapy, which is like dialysis or transplant. And now the creatinine thing. If we think of creatinine here, the GSR less than 15 comes and it depends on age and weight as well. But usually the creatinine is around 4, then the GFR is less than 15. And this is the time when patient thinks that it's okay, it's only 4. But actually the GFR has gone to the renal replacement therapy stage 5. Okay, so patient think that 3.54 is not a big deal. But at this time, you have lost both of your kidney almost totally. So creatinine, based on creatinine, if you stay on creatinine, you'll miss many patients from diagnosis and from proper treatment. This is the green zone. This shows the low risk of progression to CKD. The yellow zone shows moderately increased risk. This orange is high risk, and this dark orange is very high risk. So we can see here if the patient has 30, like if we take this example, if the GFR is 62, which is falling over here, but the proteinuria is less than 30, he stays in very good zone, very low risk of progression. And when this patient goes into with similar GFR, he develops the proteinuria increase and it goes to more than 300. Now he goes into high risk of developing ESRD or progression to CKD. So we have to understand that GFR alone is not the deciding factor, though it's very important factor. Albuminuria holds hands very significantly, and it is also very important factor in deciding the risk of progression and ultimate prognosis of the patient. Okay, so what do we do? We did, in this chart, we can see here the staging of the staging and progression of DKD. Here we have GFR. In this, the patient initial 5 years, it's a preclinical stage. In this, there is, because of the glycosuria and hypertension, there is hyperfiltration. So in these patients, sometimes there is GFR increase. You can see more than 100, could be 120, 130 could be seen because of the hyperglycemia and glycosuria. Then later on, it develops albuminuria, which lasts for maybe 10 years. And there is progressive kidney fibrosis. So this is the part that we have to deal with, because this we can control, and this we become aware very late. And by that time, the progression has already progressed to very severe state when we cannot reverse it. So the microalbuminuria develops, and they showed like 1 plus 2 plus, it could be less than 300. And the hypertension also develops with the kidney fibrosis, because it is a vicious cycle of hypertension and fibrosis. After 10 years, it develops overt kidney disease. At this time, you can see that the patient face complain that, okay, now my sugars are okay. I'm not taking any medicines, but the sugars are okay itself, because kidney metabolize the insulin. So the more than 30% of the insulin present in the body, it is metabolized by kidney. So the patient becomes euglycemic when the kidney failure develops. Okay, so patient may be happy, but it's actually the onset of severe kidney disease which they are having. Then in this state, the progressive fibrosis, the rise in GFR, rise in creatinine, decline in GFR, very severe rise in albuminuria, and later it develops CKD and ESR. Okay, so these is the chart, these 10 years, and this is the time when if we internally here, the patient can be saved and from developing cardiovascular and renovascular disease both. So, what is the importance of USCR? We can see here that this is the baseline. If USCR rises, the all-cause mortality in CKD patient rises. Okay, so this is very important thing. It's not just to stop the progression of CKD. It is to retard the mortality as well. And also in CKD patient, if USCR rises from baseline, we can see here the cardiovascular mortality also rises. And this is one important fact, that the most common cause of mortality in DKD patients is cardiovascular, not renal problems. So very less of the patient, they die of the kidney failure or some other complications. But the first common cause is cardiovascular mortality. So these are the important aspects that we have to look more seriously. Okay. Why is not moving? Just hang. Okay. So what the guidelines recommend that we should. Sorry for the disturbances. I can't go back. I will just replay. Okay. So we were on this slide. Okay. So the guidelines recommend that we should do the GFR and USCR annually, so that we do not miss the diagnosis and we pick them early and we treat them accordingly. Okay, so USCR is very comfortable test because it's very convenient. We can do it on single void spot urine. We do not need to measure the 24-hour collection, which is cumbersome for the patient. And sometimes because of this problem, we miss the diagnosis because patients do not deposit the sample and later on we pick them up later. But USAR can rise, that the 24-hour urine are also affected by these things. If you have exercise in 24 hours, or you have infection, fever, heart failure, marked hypoglycemia, menstruation, then there might be some elevation in the USCR. And if we consider the treatment effective, if there is 30% reduction in the UACR, so if you are putting them on some treatment, then you should monitor within 2 to 3 months or maybe 6 months. There should be around 30% decline in the UACR. Then we think that it will slow the CKD progression. So there are many drivers apart from the current therapy like sugar control, like hemodynamic control, the glycemic control. There are many drivers towards the development of CKD. So we have to look each of them and we should see how can we start the progression of CKD. This is the trial. It was, as we all know, the RAS inhibitors are the mainstay of therapy in DKD. And for that matter, any other CKD, it should be given in all the patients who are having CKD if their parameters allow them. So with the hemodynamic control, we first tried with the hemodynamic control. If we do the proper hemodynamic control and we block the RAS, then are they actually having residual, are they having, the risk of progression is lower. So we saw compared to placebo in the NAR trial with losartan, the losartan arm showed the reduced risk of progression, but it was there. The progression was still there, though it was less than the placebo. In INDT trial with RB, AMLO, and placebo, we saw the risk was less in the RB arm, but it was still there. So we did the hemodynamic plus metabolic control very nicely. We introduced SGLT2 inhibitors, and then we saw in Tredence, DEPA, and EMPA. In all these trials, we saw that compared to placebo, the Cana arm is doing good. The CKD progression, the primary endpoints of kidney failure, doubling of creatinine, they were all lower in all these trials. That is why these drugs are now properly guideline recommended drug. They should be given in all the DKD patients. But there was risk still there, despite they are properly managed for hemodynamic, for metabolic, and whatever personal factor we could see. But still there, it was there. The CKD was still there, though at a reduced level, it was still there. So then the protocol came about the most new paradigm. This is most recommended paradigm about the pillared approach. So there are 4 pillars toward the treatment of DKD. We for decades we know that we must give them RAS blockers. Now we have also introduced SGLT2 inhibitors in all of our CKD and DKD patients. Then we have Findenal, MRA, and then we have GLP-1 analogs. So they all have different mechanisms of action and sometimes similar in 2 or 3 groups, but they all together they are doing good for the patient. So RAS blocker, they dilate the efferent arterioles, and that's why they decrease the hyperfiltration, and they also decrease the interstitial fibrosis and remodeling. SGL2, they dilate the efferent arteriole, and they do the proteinuria, hyperfiltration, they decrease the oxidative stress, and so on. So they also have very much anti-fibrotic property that are very fast. Then the Findenol, the non-steroidal MRA, it decreases inflammation and fibrosis. Its most important role goes into the fibrosis and endothelial dysfunction. The GLP-1 RAs, they decrease weight, they decrease the endothelial dysfunction and the oxidative stress. So these are the 4 pillar therapy that should be recommended whenever possible in all of our patients who have DKD. So what is the role of MRA? MRA overactivation leads to increased aldo and cortisol, which actually increases the inflammation and fibrosis. So they work on all the 3 factors, that is the inflammation and fibrosis, hemodynamic control, and the metabolic control. So these 3 factors when together, they damage the kidney properly and they also damage the heart by the almost similar mechanisms like the IFTA, tubulointerstitial fibrosis and damage, glomerular hypertrophy, expansion, and glomerular sclerosis. In the heart, they do atherosclerosis, vascular stiffness, hypertrophy, and myocardial fibrosis. So that is why we deal with those 2 conditions together in our DKD patients. So these 4 things, they are working together in synergistic way to help our patients. Okay, so RAS blocker, along with the Fendrinol, they decrease manage the hemodynamic problems and the inflammation and fibrosis. The SGLT2s, it manages the hemodynamic and the metabolic dysregulation. The GLP-1 manages the metabolic dysregulation and also works on fibrosis. Okay, so the take-home message for today's DKD management is that we should not stay with the creatinine. We should measure GFR and we should see the UACR at least annually for our patient who have DKD, who have diabetes, so that we can pick them up early, and before they land up into ESRD, we can properly manage them in time. And we know that early CKD patient management is usually frequently missed because of the late diagnosis. So the problem is awareness. Patient do not get checked their USCR, creatinine, GFR. When they have complications like they have albuminuria or decreased renal output, or they have puffy eyes, maybe breathlessness, these are the signs of, or weakness, they are signs of DKD. Then they get tested, and then it's already very late to actually give us the condition. So despite the standard RAS blocker and SGLT2, patient actually remains at risk of CKD progression. So whenever possible, we should give them Findinal and the GLP-1. GLP-1 is a costly drug, but it might be introduced. And there's one more doubt with the patient. They think that RAS blockade along with Findinol, they might cause hyperkalemia. Are they recommended? Yes, they are recommended. In fact, in all the trials which were there, they were recommended together, and there was no increased risk of hyperkalemia, but these patients should be monitored, and there are guidelines to how to monitor at what time and how to taper our therapy. So MRIs are actually recommended. They are good drugs. And then Ferdinand demonstrated very much highly efficacious in slowing CKD progression and preventing cardiovascular events. So that is all about the DKD progression. And if you have any doubts or any questions, you're more than welcome. Thank you so much for a patient listening.
Thank you, ma'am, for a very comprehensive and a very crisp presentation. Ma'am, if you can just like remove the slide so we can start with the question answer session.
Yeah, sure. Just do I have to do a stop share? Okay.
Yes, ma'am. Thank you so much, ma'am. Ma'am, you mentioned regarding the cardiovascular mortality being high in DKD patients. So when it comes to the DKD patients with rapidly declining EGFR and with a high cardiovascular risk, how do you prioritize the treatment in such patients?
See, we cannot actually do retard the CKD progression or not retard the cardiovascular risk. It is going hand in hand. Once you manage the CKD properly, most of the drugs are recommended for cardiovascular disease prevention as well, like SGLT2 inhibitor. SGLT2 inhibitors, they are doing very good. They are decreasing the mortality in for CKD as well. In non-diabetic CKD as well, they are recommended. And also in the DKD patients who have diabetes, this CKD, this is recommended. And these drugs have shown very much decrease in mortality. So this is one thing. Similar goes with Findinal. Findinal is also have shown to be effective in the DKD as well as for cardiovascular problems. So I think if you manage the DKD in a better way, in a proper guideline-based manner, then definitely you will retard the cardiovascular risk factor as well. And if you do not let the DKD progress, the mortality by cardiovascular disease already goes down.
Okay, ma'am. Ma'am, you mentioned about the glycemic control as well in your slides. So even after optimizing the glycemic control blood pressure and with RAS and SGLT2 therapy, there has been a substantial renal risk which remains. So which biological pathway do you believe contributes most to the residual risk?
The fibrosis, interstitial fibrosis is, and the glomerular sclerosis, which is always there, where I showed in a slide that it is always there, even if we do the very good hemodynamic control and we do very good glycemic control, it is always there. So there are many missing factors which we still don't know, and this such is going on to understand them. But yeah, there are few factors which have been explored, which we know that non-steroidal MRAs and GLP-1s, they are actually very effective in slowing the retardation, though it can never be negligible. Yes, but it can be retarded to a very significantly at a lower level, so that we can save patient and we can uh, stop them from getting into ESRD stage, need of transplantation and need of dialysis.
Thank you, ma'am. So one question was regarding to the discount findings. So in patients with discordant findings, especially when it comes to normal EGFR, but persistent albuminuria or declining EGFR with minimal albuminuria, which phenotype carries a worst long-term renal prognosis according to your experience, ma'am?
Okay. So, if you ask me personally, I think it's the EGFR that I focus more, because GFR is a deciding factor for your CKD progression. When you give some medication, like if you give them RAS inhibitor or maybe some SGLT2 inhibitors, initially for like initial 2 to 3 months, you might see that there is some decline in GFR as well, because they decrease the interglomerular hypertension. Because of the hypertension, there is hyperfiltration. That is why there is hyperalbuminuria, that the proteinuria is there. So once they decrease that aspect, it's like a slapping a child who is actually doing some bad work. They are slapping, they are being slapped, but they later on they are actually for good. Okay, so the kidney understand that hypertension is not good for me. So I will actually decrease the hypertension, intraglomerular hypertension. So later it will decrease the proteinuria, and so that is why you initially might see some GFR decline with these drugs. So one finding is not the epic thing. You should actually follow up the patient and see the GFR is declining or not. Initial decline is actually presumed. And then if you see the albuminuria may be very less in burnt down disease. When the patient had developed very severe ESRD, there's no GFR left, the filtration also goes very down, then proteinuria itself decreases. So the proteinuria, when actually it's not the one way thing that you actually mark the GFR at the prime thing, but they both are significant. But in terms of if you have to decide properly, then GFR wins, I think, because that decide the treatments and the drug therapy and the prognosis in the long term.
Okay, ma'am. So, ma'am, ideally, EGFR should be considered as the therapeutic target. Like in diabetes management, HbA1c is the most therapeutic target. So, in that way, EGFR should be considered rather than the albuminuria itself.
Yeah, right. The GFR is the most important deciding factor, along with proteinuria. We discussed in a one slide that albuminuria is there, and that also at the same GFR, if albuminuria rises, it puts the patient at a higher risk. Okay, so albuminuria cannot be neglected in early stage. In fact, when GFR is 90 or maybe 95, it is the albuminuria that decides that the patient will develop into ESRD or not. If you manage at 90 GFR, if you manage albuminuria well, he will might not develop the ESRD in long term. But later on, when the GFR like 30 or maybe 40, then the GFR management is more important. In early stages, albuminuria management is more important, because at that stage there are many drugs which are thoroughly effective, like RAS, like Vindrinon, like SGLT2. You give them these, and patient will have a normal lifespan. They will have a better glycemic control, hemodynamic control, and they retard their kidney disease. But later on, when the GFR goes really low, like it's like 40 CKD stage 3, then the GFR is a deciding factor, because you cannot give many drugs at that GFR, first thing. And then when you give these drugs, you have to monitor for hyperkalemia. Like RAS inhibitor you give, you have to monitor. Okay, one thing that there is in all the patients' mind, in the doctor's mind as well. In fact, when I was doing MD, I also used to think that I should not give CKD patient a RAS inhibitor ARB. It might lead to hyperkalemia, and hyperkalemia we are really scared of because it might lead to complete heart block and patient might die. He might not even reach the hospital. While the treatment is very simple, the patient gets hyperkalemia, he has 20 pulse rate or something, you just give them dialysis or you just give them antikalemics. It works like hell. Patient just improves and gets up in 2 minutes. So okay, this is the very important thing, that we can manage them. We should give them proper dietary counseling as well. So, but you, every patient with CKD who has low GFI, 40s or 50s, they must be given RAS and ARBs and even Findrinon, and then we should see if there is hyperkalemia, it is rising every weekly or later on monthly, or the decline is GFR is more than 30% or it's very significant and it's progressively rising, then we should stop the drug for some time, give them proper counseling about do not take black salt. Like patient think the Senda salt and the black salt are safe. They are not. They are not safe for kidney patient because they lead to hyperkalemia. They have high and they preserved canned food. They have very high amount of potassium. So these patients are at risk of developing hyperkalemia. So they must not be given. But patient after monitoring, if the potassium remains in the level and their creatinine also not rising, then we must give all the patient, all CKD and DKD patient, they must be given SGLT2 and RAS inhibitor and the Findinol.
Ma'am, how do you see the change in the landscape after the introduction of MRAs? Because as you mentioned while you were doing your MD, so there was a concern with regard to the hypokalemia in the patients. So how do you see the change in the landscape of such
Yeah, they,
patients?
personally, when the MRAs and a RAS, you cannot give together. MRA is like normal MRAs, like L-ductin, spironolactone. This is the concept and the guideline recommended as well, that when we did give them both together, both in cardiac patient and CKD patient, they must not be given together because there is no added benefit, but there is very much increased risk of hyperkalemia in these patients and then leads to cardiovascular death. Okay, but RAS inhibitor with non-steroidal MRAs like Findinol, they can be given. This is the study which were like Fidelity. These are studies they were done. They were given RAS and Findinol, and these patients, they need to be monitored if they're in a very low GFR range, like 40s or maybe 30s. Then they need to be monitored. If the potassium goes more than 5.5, we should stop them temporarily and we should start them at a lower dose, 10 mg. And if it is high, then we should do the dietary consult later. If it is there normal, like less than 4.5, then we could restart and see and follow up. This is the protocol and it is effective. Personally, I feel when the non-steroidal MRA has come, since the introduction of these drugs, the proteinuria is like very, easily manageable. Otherwise, initially with the RAS alone, because RAS also, we have to monitor BP as well and the potassium. If the patient cannot tolerate this drug because of the hypertension, like hypotension is developing to the RAS inhibitor, then we have to stop the drug or decrease the dose. It is actually recommended in maximum tolerated dose. So with the introduction of Findinol is actually not doing much of the hypotension thing. It is not effective on those aspects of the MRA receptor. It does work more on the fibrotic factors. So it is antifibrotic. Apart from hemodynamic control, it does the antifibrotic effect. That is the wonderful effect. That is why it decreases the proteinuria very significantly. And also the GLP-1. GLP-1, we talk less about it because it's very costly therapy. It's sub-Q therapy. It is though weekly therapy, but patient actually cannot afford this much. But yes, if given in proper indicated patients who are obese, who have uncontrolled glycemia, despite all those drugs, then yes, this is a very effective treatment. It retards the fibrosis. Apart from the glycemic control, it retards the fibrosis in the CKD. So it's actually very effective.
In terms of fluid management, do you recommend giving diuretic and MRA separately, or do you think combining both of them will give a synergistic effect to the patient?
Yes, at very low GFR, like less than 30 GFR, we cannot give MRAs. Okay, but at higher GFR, they are recommended, and synergistically they work. Yes, they given together, they manage the fluid overload properly and more efficient.
Ma'am, what combinations of diuretic and MRAs do you prefer usually in your day-to-day practice?
I usually I do not give them MRS. Most of, like, I give them the loop diuretics and the metolazone. This is the combination I prefer because they have more efficient and synergistic effect. MRAs, actually I don't give them much because my patients are already on RAS inhibitors, and I already told you, with RAS I cannot give them MRAs. Okay, risk of
Ma'am, looking back to the patients who have reached on dialysis already, what was the earliest missed opportunity that could have changed their trajectory?
This is the most important. It's the proteinuria. It's the proteinuria. I have made many videos online. I posted them. I tell all of my patient come, and creatinine is 1.2 or 1.5, and proteinuria is just 1 plus. They even miss it. They say urine report is, ma'am, normal totally. Then I told them, let's see, the protein is 1 plus, because some doctor or maybe some technician, they test, it's okay. Creatinine 1.5 is okay. It is not okay, because creatinine 1.5 is okay for patient maybe 70 or 80. At that age, we expect the creatinine to be 1.5. But at your age, like when you're 20 or 30, the creatinine should be more like 0.6, 0.7. It goes to 1. That is also abnormal. And with the patient or GPs, they keep waiting for the creatinine to rise, and up to 2, they consider it's okay. When actually the creatinine is 2, the GFR is usually less than 60 or maybe 40. It depends on age as well. So that is my one important message to all of you, that when we remove one kidney, okay, we do donate for the transplantation. The donor creatinine is actually one. It's one only. Okay, but the one kidney is lost totally. Okay, so if we just see the creatinine, we will miss half of our patient, more than half of our patient. Okay, so that is why the kidney creatinine doubling starts when half of your function is lost. Okay, so when we have 2 kidneys, you have 100 function. When the creatinine doubling starts, you have 50% of the function already lost. That is why you should not stay on the creatinine. You should measure GFR. It will give you a true prognosis and true statement of kidney function and the albuminuria. As I already told you, at early stage, albuminuria is the marker. GFR may be 60, 70, or maybe 80. But proteinuria is there, which is showing like 2 grams, 3 grams, or 10 grams. This is the stage. If you intervene then and there, it will be like managed profusely, and it will be, you will save the patient's life, cardiovascular mortality, and development to ESRD. So at early stage, proteinuria 1 plus 2 plus should not be missed at all. They should be properly investigated. We should measure the UACR, the protein creatinine ratio, and if not, we give them RAS. If not, getting, and then they to measure, to monitor, there should be 30% reduction, at least 30% reduction, and the target should be less than 500. Like if it is 3 gram, it should be less than 500 over a span of 4 to 6 months. If it is not declining, or GFR is rising, GFR is declining, then you should refer the patient as soon as possible. Once it is 2, already we have actually lost half of your kidneys. Okay, so don't wait for creatinine to rise. This is the misconception that we have to wash out of our minds.
So, ma'am, proteinuria, creatinine is one of the key markers in the early detection of CKD,
Right.
and one should never overlook that in the early diagnosis.
Right. This is the important message.
Ma'am, one last question. As per your understanding of diabetic kidney disease, the landscape has continuously been evolving. What do you think is the biggest paradigm shift the clinicians should embrace today, and your message to the physicians who are watching us today?
Yes. Yeah, I think all of us, we are scared of introducing RAS inhibitors, and we are actually doing SGLT2s only with patient who are having diabetes. And if the patient diabetic, like they improve, like I told you, the patient who have severe nephropathy, advanced stage, then the insulin metabolism, which is done by the kidney, it goes down. So the insulin which is there in the body, it is also sufficient. So the sugar levels becomes normal. Patient become euglycemic. Then also patient is euglycemic, then also you give them SGLT2 inhibitors. Okay, that's very important because it doesn't cause very much of hypoglycemia. I haven't seen any of my patient getting hypoglycemia because of the SGLT2. They might get hypoglycemia because of they got some fever, some infection, and they were not eating anything. So then they might have end up in hypoglycemia, but not because of the SGLT2 alone. So you must put them on RAS inhibitors, ASS, ARBs. So ARBs are little costly. If you have poor patient, you put them on AS inhibitor. This is very cheap drug. It controls the BP, it decreases the proteinuria. And if the patient were on some amlodipine, the local patient, they are actually taking amlo plus 80 or something. So you shift the antihypertensive drug to your RAS inhibitor. This will do magic to your patient's life and progression towards CKD. SGLT2, even if they are euglycemic, you give them SGLT2, they will do the wonder in kidney progression. And if possible, as I already told, these are the important drugs. If possible, Findinone and GLP-1 are costly drugs. If possible, you put them on those, and they will do definitely the decrease of fibrosis, and they will do wonders in those patients in whom they are recommended. But yes, RASes and SGLT2, they must be given all patients, whether they are non-diabetic as well. Then they must be given on those patients as well. With the SGLT2 introduction, yes, I think this is a event which has changed the treatment protocol thoroughly, and they are also not very costly. That is why I advise them to be given to all of our patients.
Thank you so much, ma'am, for a very comprehensive presentation. With this, we come to the end of the session, and I would like to take this opportunity to thank you for sparing your time and sharing your valuable insights and a very practical perspective when it comes to the diabetes kidney disease management and the practical and valuable insights on the different aspects that you covered with regard to the treatment modalities as well. Thank you so much, ma'am. I would like to share with the audience that this session is available on YouTube. The recorded session will be available, and you can comment or share your thoughts or any questions that you would like to share with Dr. Neha Jain, ma'am. Thank you so much, ma'am. We look forward to your support and guidance for our future initiatives as well. Thanks a lot.
I'd like to thank the team and all the doctors. Thank you so much for being here.